Well, what good is it gonna do me to quit now?
Can go out and we can promote these screenings, but maybe we don't have the right health care.
What does a low-dose CT look like? What are the risks of screening? What are the benefits of screening?
Absolutely. I'll call. They'll say, no, I'm not interested.
How would you approach that conversation?
Who's gonna make sure that they're hearing about their results? Who's gonna make sure that they're gonna get to the next step safely?
Patients are like, absolutely, I don't want to do this.
Screening for cancer, and it's a risk-based screening. Years ago, lung cancer, a diagnosis of lung cancer was a really scary diagnosis.
Earlier staging. So they are catching the cancers earlier when they're much more treatable.
Doctors don't really know about it or recommend it.
It's not like that anymore.
What does the follow-up look like?
Radiation causes cancer.
Any age is okay to quit smoking.
How we screen or what we look for.
You can quit now and you're gonna feel better. You actually are gonna notice that things will get better for you.
Welcome to Everyday Epidemics, where we explore critical topics shaping the future of public health. Today, we're diving into the OHSU lung cancer screening program. It's a transformative initiative redefining how we approach early detection of cancer. I'm joined by two remarkable experts leading this work. First, Dr. Katie Putnam. She's a family physician who blends her passion for clinical excellence with leadership in population health, quality improvement, and informatics. Dr. Putnam serves as a co-medical director of the program, and she brings her invaluable expertise to this initiative. Joining her is Ann Spencer, a nurse navigator with over 25 years of experience in pulmonary medicine. Ann has been guiding patients through lung care long before nurse navigation was even a recognized term. At OHSU, she's been instrumental in developing and refining their lung cancer screening program. In this episode, we'll discuss the critical role of nurse navigation and why every program needs someone like Ann. The challenges providers face in offering lung cancer screenings also address these perceptions surrounding lung cancer diagnoses, navigating patient-provider dynamics, and nuanced topics like when is the right age to quit smoking? Let's dive in. We want to start this with learning more about you and the work you do respectively. And I work in public health on kind of the upstream side of things and a lot of like, how do we get people to not smoke or not start? But I don't know a lot about the work that you do and what happens on that downstream, your patients and all of that. So can we talk a little bit about that?
Sure. I'm a family medicine doctor. I got a master's in public health in my medical school training as well. And so also super interested in the upstream. I was lucky to be able to serve as one of the co-medical directors of the screening program that we started up in the past years here at OHSU, where I get to work with Ann. And so we're just working on increasing primary care comfort, talking about screening with their patients, giving patients autonomy to bring it up with their clinicians and their care team, and figuring out how we can get people screened so we can catch lung cancer earlier.
Thanks. So I'm a RN nurse navigator for lung cancer screening, and my whole role is kind of being the bridge between the primary care of the patient and making sure they understand screening, actually getting screened, and then getting follow-up prompt on whatever their screening results turn out to be. And
Do you get to see the patient after they have a diagnosis of lung cancer, or is this sort of before that?
before that, I'm on the front end of things. So once they do get a diagnosis of lung cancer, then they go on to our lung cancer team, if you will.
What's one of the biggest challenges that come with that role?
Figuring out a right smoking history to make sure a person meets the criteria for lung cancer screening, because very specific criteria of who screening is most effective for is finding lung cancer early.
Yeah.
Yeah.
What are we seeing? I don't know, in terms of like, what have the recommendations changed over time? Are they different now than they were before? What does that look like?
They've changed just a little bit. They're always doing research and whatnot. Right now, the recommendation is on cancer screening is recommended. It's a yearly low dose chest CT scan done on patients between the age of 50 and 80, or people between the age of 50 and 80 who have a smoking history of the equivalent of a pack of cigarettes a day for 20 years, whether that be a half a pack for 40 years or whatever the numbers come out to, and having smoked, current smoker, or have smoked within the last 15 years. And before that, it was a little wider. The smoking, the amount of cigarettes you had to smoke for screening was a little bit bigger, and the age categories were different. So they've narrowed it down. They're getting good at fine tuning who the most appropriate person is to be screened for lung cancer, where we can be most effective.
And we have sort of this new advent of vaping and other types of nicotine products. Does that affect how we screen or what we look for?
That's a really good question. Not yet. There are a lot of emerging studies about the risk of lung cancer with vaping. We know that there's an increased risk. It's probably not as much as folks who smoke cigarettes, but what we find, especially in my roles of primary care, the modality of vaping is really dynamic, and so there's some high concentrators, there's lots of different products, and so I think right now we're actually figuring out collectively how to best measure, and then we'll have to kind of watch that risk over time. But right now, folks who vape, that is not a part of the USPSTF recommendation for lung cancer screening. But we'll have to see what that looks like in the future. I wouldn't be surprised if there was some caveat for that later.
And what does that look like? So the process of you seeing a patient to them getting screened or being recommended for this low dose CT screen.
Yeah, that's a great question. So, we do many things in a brief visit in primary care. And oftentimes during my annual, or if I know a patient, I might only see them that one time a year. I'm going to try to get as many things wrapped around for them. Some of it will come up naturally when we're talking about is someone still smoking? Hey, what have you done so far? How can I help you quit? Are you interested in quitting? What have you tried? Let's go for it again. And then if they meet the eligibility criteria, you can talk a little bit about what does a low dose CT look like? What I found as a barrier is time, though, because some people have a lot of questions about it. It's appropriate to have questions, and we want to share with people what are the risks of screening, what are the benefits of screening. And that's where Anne comes in and has really helped us take this program off. Is if I go, oh my gosh, I'm out of time, or I realize that after the patients left, is like talked about smoking, but we didn't quite talk about why I would recommend low dose CT for lung cancer screening. Anne will then reach out to the patient and say, hey, I work with Katie Putnam. She wanted me to give you a call and talk about this. And so being able to get someone to have a conversation so they understand exactly what they're signing up for. What does the follow-up look like? A lot of people have thoughts about what they might find. They're worried about it. Who's going to make sure that they're hearing about their results? Who's going to make sure that they're going to get to the next step safely? And who's going to follow up on them if they say, hey, your scan's all clear. We'll call you in a year and make sure you get back in. Having nurse navigation and having Anne in that role has been really impactful at increasing our rates here at OHSU.
And when did this program start?
With OHSU just a year ago. I'm on my 1-year anniversary. Lung cancer screening itself, I believe, started about 2014 is when it first came to the forefront. So, yeah, I think OHSU started their program maybe 2 years ago, and now we're really rolling with the program.
Yeah. Have you seen any sort of immediate success from the program start?
Yeah, I don't have numbers for you, but yeah, I know because now I've been here a year, so people are coming back for their next annual scan or next yearly scan, and the numbers are growing and growing. So that's great. People getting screened.
Yeah, with our strategic approach, we have increased our screening rates quite a bit. But the other thing that's interesting is with our interventional pulmonology team is when they're going in to actually sample worrisome nodules, they're getting earlier staging. So they are catching the cancers earlier when they're much more treatable. And so that to me looks like success. And we're pretty much a year in at this point and having, kind of building things as we go. And so to see that already, I think that we've got a lot more opportunity in the future. And it's just really exciting how much we've been able to get folks screened and get them in quickly to look for things like cancer earlier.
And you touched briefly on it, but what really are the benefits of a program like this for patients? Yeah.
Yeah, I am such a huge fan of the nurse navigation in this role. And I I think that is a strategy that you can apply to so many different things in healthcare systems. But there's so much that a primary care team member or a specialist may need to do that making sure that a patient has holistic, patient centered, and wraparound care. Sometimes there just is not time and we don't have the teams for it. And so if you have someone that people go, I know as a PCP, I can call Anne and talk with her about this. I can make sure that Anne is going to follow up on this. Anne's going to call a couple times. She's going to send in like an EHR message to patients. She's going to get a hold of them. Um, Knowing that you have someone to trust that can help the patient and the patient knows Anne. They know, hey, actually, I thought of another question. They can pick up the phone and they can call Anne to say, well, wait, where is the LDCT? Which part of our campus is it at? Or when should I know the results? Or what is this other thing? Like, what does this word mean? Does my PCP know about it? And Anne can be a trusted point person. And so that to me is the biggest success is having a glue like nurse navigation that can help folks get to wherever they may need to be in the screening or diagnostic process.
What do those conversations look like for you when you're talking with patients? And do they have worries or concerns or fears? How do you navigate those situations?
Sure, of course they do, right? We're screening for cancer, and it's a risk-based screening, right? So we know that if you're getting screened, you're at a higher risk already for developing lung cancer. So yeah, they are scared. So, I'm fortunate. I have a lot of experience in this world as far as lung cancers and lung nodules, and that helps. And there's some great risk calculators out there that I use, and I'll go through the risk calculators with the patients. I actually have an app on my phone with one of them, or I use a website, Should I Screen? And we talk through and enter their information, then talk about the computer tells me what their risks are, and we talk about it. And then we talk about what a LDCT scan is and when to expect results and what if we find something, then what? And so we can talk. Some patients, people really want to know and really are thoughtful about making their decisions. And some people are just, yep, let's just do it and get it done. Yeah. So it can be a 2-minute conversation or a 20-minute conversation. I have the time because that's what I do. Yeah. Where primary care might not.
Is there any sort of pushback on any of this, or do you have patients that are like, absolutely, I don't want to do this for reasons, or what does that look like?
Absolutely, I'll call they'll say, "No, I'm not interested." Most of them are, "Thank you, I'm not interested," but they're not interested, and that's fine, they have a right, they've been as informed as I can be with them or their primary care, and if they don't wanna be screened, that's okay, then we'll ask them again next year. No, I keep
Yeah.
bringing it up until sometimes they decide, and some people it takes a while, yeah.
Why do you think patients maybe not be ready for this type of screen?
I think, years ago, lung cancer, a diagnosis of lung cancer was a really scary diagnosis because we didn't have good treatments. We didn't have good ways of finding lung cancer early. I said I've been in the business a long time. There didn't used to be screening for lung cancer. So we'd find it at the later stages when it wasn't as treatable or curable as now when we find it early, it is treatable, curable. And so I think people still know they remember their grandpa that had it and he was gone in 3 months or whatever. And it's not like that anymore.
Douglas County, where I live, is a very rural place. We have one hospital, and it seems like a lot of people aren't getting the screening, or even their doctors don't really know about it or recommend it. What are your thoughts on on that aspect of rural healthcare, and how can we improve those? Do you think you'd recommend it for those areas, or
Yeah, I think it's definitely recommended for anybody who meets the criteria, but you also have a plan. What we're going to screen a person now. What do we do when we find something? Do we have a place where they can go to get the care that they need? But getting the information out there, getting the knowledge out there, always coupled with smoking cessation. Smoking cessation is very important, as we all know. So, yeah.
one aspect I've heard patients talk about is uh, you know, radiation causes cancer. And now we're doing this low dose CT scan, and we're going to have, more radiation. Is the benefits versus the risks? How would you approach that conversation?
Yeah, no, that's a great question. I do get asked that, and I'll give you the my best understanding. Understanding I'm a nurse, but I recently talked with my mentor, who I would consider the father of lung cancer screening for the most part in Oregon, Dr. Mark Deffelbach, and he described it to me as one LDCT scan is about equivalent to traveling in an airplane across country because you get exposure from radiation at that. Um, it's my understanding that they've done the best they can to minimize radiation exposure with the low dose CAT scan. So it's a lower dose. And then it's a cumulative effect over time. So I understand it takes about maybe 30 years for any radiation effects to start showing. And we all believe that the risk or the benefit outweighs the risk.
Hey, it's Mitchell here. I just wanted to take a brief moment to talk about our DC Smoke Free campaign. We are tackling the impact of nicotine products in our community by providing resources and support to help folks quit and stay free from nicotine. We're also constantly adding new materials to our website, like blog posts, articles, videos, and more. So make sure to check back periodically for fresh resources. Visit DCsmokeFree.com to join our movement and explore everything we have to offer. Okay, back to the podcast.
The point of screening is to identify a lung nodule or lung cancer now. And this idea of the cumulative effect and this timing is, well, yes, radiation does have a little bit of risk. It's low. But if there's a lung cancer that we're missing, that's much higher in terms of the things that we should be worried about and things we need to deal with today and maybe not in the future. So agree with Anne on that.
And you also have a degree in public health, is that right?
Yep, that's correct.
Uh, why a degree in public health? Are you have interest in that, or?
Yeah, I was fortunate to be a part of the dual degree program at OHSU where I got my MD and my MPH alongside each other, and I think to me they're very closely intertwined. So it helps to have the perspective of population healthcare. How do you operationalize these things, all the complexities, and how do we care for every single person in our community? It gives a little bit of a different lens and a viewpoint than just clinical medicine does, and I think they enhance each other. So that's part of the reason I became interested in this work is to make sure that we could care for populations as a whole, while I also get to care for the folks that I see on an individual basis.
Do you get to bring aspects of public health into your daily practice when you're interacting with patients?
Sure. Yeah. I think talking a lot about these USPSTF A and B guidelines and then meeting folks and having these risk benefit conversations to me is, is this something that we're asking of folks for a public health benefit? How do you stand to benefit? How might your family benefit? What does this mean for you and your community? Those are all things that I think about. And then I think when we have challenges in healthcare, having a public health lens or someone who has a slightly different focus can help to identify other opportunities for improvement.
What is maybe a couple of things, one or a couple of things that folks like me in public health would benefit from knowing about that direct clinical care? I don't have a lot of access to that. I don't have the knowledge that you have, but I work with lots of patients who have maybe these questions, and I refer them off, to the appropriate resource. But if there's something that could benefit folks like me, is there some things you'd recommend or say?
That's a really good question. I think, it's funny. Some folks, when they come in, think that there's only certain things that they can talk with their primary care about. Someone may have been thinking about quitting smoking. Someone may be wondering if the secondhand smoke when they grew up, what that might do for their health, but they might not be comfortable bringing that up with their care team. I think for anyone in the public health realm, it's important to let folks know yes, bring all of your concerns. That's totally the right place to do that and also, when you're seeing things, that's really important. When folks are out in the community, they say, this is really curious what's going on. I'm noticing this trend. Are you all seeing this? Sometimes I'm hearing from patients about stuff that I need to look into. And I go, oh gosh, I didn't realize that that was information that was being put out there. So let me look into that and get back to you on that. So I think there's a real interplay. If you're noticing trends, communicating with the clinical team, but also empowering patients to and folks to just feel comfortable sharing their concerns, bringing their questions, saying, hey, I did go to Google and I looked up this stuff and is this legit or is this something that maybe I was misunderstanding? And so being able to have that relationship with primary care, I think is really important. So, um, and I love all the folks who are doing frontline public health because I think that work is so important and so impactful. So thank you.
With vaping, other nicotine products, that really is one of my biggest concerns, especially among youth. Are you having patients um, talk to you about vaping or talk to you about their nicotine use? I know that, so the data that I have in Oregon is that the number of youth using cigarettes is down to about 3%. I don't know if you've seen those numbers too, but which is great. It seems like you have done a fantastic job. Public health has done a fantastic job about getting those numbers down. But the numbers of nicotine use, especially with vaping, Zyn, nicotine pouches, are really exploding. What is your approach to some of those things, especially maybe within the realm of this program, or do you expect this program to change in the near future with those kind of new things coming about?
I think one of the lovely parts of this program that we were able to do is work with some tobacco cessation counselors, and that is now available to everyone. Um, and that is a really wonderful team member to have too. So we have two folks that are able to talk to anyone. So if any patient comes in, if a teenager comes in, if an adult comes in, and this can be out of the scope, obviously, for the age confines of lung cancer screening, anyone who's using any nicotine or tobacco product, we can have them have a conversation. We can get you patches, we can get you lozenges, we can talk about other tips and tricks that folks have used. We have folks that'll cessation counselors will call and check in on you. I think that the key is asking everyone, normalizing that this is a conversation you should be having in the primary care setting or with anyone. If you go and see your surgeon, you need to let them know if you're using anything. Some people are not going to offer up the information themselves because they're worried about perceptions of stigma. But really, we're here to help and support folks wherever they are in their journey, whether they're just starting to think about what cutting back or quitting looks like, or whether they're ready to stop now. And there's all kinds of tips and tricks and other folks on the team that we can have. So I think the vaping question, folks who vape are not yet in the lung cancer screening program, but vaping is certainly a health concern that we should be talking about with more folks, and I notice the trend too, especially adolescents and early adults, much more likely to report vaping in my practice than they are cigarette use. So when we ask someone when they get roomed, "Do you smoke cigarettes?" and they say no, we're missing the opportunity to say, "Are you using tobacco products any other way? Are you using chew? Are you using any vaping or e-cigarettes?" And folks go, "Oh, yeah, actually, I was smoking years ago. I quit, but I switched to e-cigarettes and now I'm good." And so you'll go, "Well, actually, let's talk a little bit about this, unpack
Yeah.
that." So we need to intentionally ask anyone who interfaces with us about what their relationship with tobacco or nicotine is like.
Mhm. Do you talk with patients often and they sort of bring up, "Oh, I vape or I do the other nicotine products." How do you approach those conversations?
Well, my patients are in the age range of 50 and older. They don't bring up vaping so much as they bring up marijuana.
Oh,
And
yeah.
well, I quit smoking cigarettes, but what about the marijuana? And that's a big question I get asked a lot, which that doesn't qualify you for lung cancer screening. But you probably shouldn't do that either. Anything you bring into your lungs is not good.
Just because the research isn't there about THC use in marijuana or
And correlation with lung cancer, yeah, yeah.
and so I wonder if maybe, yeah, it seems like maybe this is we just don't have the studies to show that yet, but there could be a high probability that, cannabis use, especially anything into your lungs, could cause cancer. We just maybe don't know.
Right, right. Plus, I think it's way easier to smoke a pack of cigarettes a day than it is to smoke 20 joints a day or something.
Okay.
So you're not taking in as much smoke.
So quantity is a bit is an issue there.
Yeah.
Same with, lung cancer risk with cigarette use is really a dose response. And that's why we use this idea of a pack year. And so we know that the more frequent and the more intense your response, your risk goes up from there. And we haven't quite figured out how to quantify that. There's a thought about joint years for marijuana use, but there's some studies that show that maybe there's an increased risk for lung cancer. There was another kind of bigger picture one that said maybe not so much. So I agree with you. I think we need more data. And as we start to study inhalation of cannabis, it'll be important for us to see, well, what does that risk actually look like? Um, but that's kind of to be determined.
Yeah. And I haven't even thought about the quantity or the amount, you're using per time. But if you think about vaping, right, we're seeing lots more people who are using this more and more daily. It's much more accessible. They're taking hits all of the time. So they're, maybe, the thing is they're a little bit safer than cigarettes, right? That's the idea. That's how they're marketed. Uh, but the quantity is way higher, and so I imagine that as we get more studies and more info, we might continue to find these things are worse and worse and worse for us.
I wouldn't be surprised either, but you're right. It's that because we talk so much in pack years, it's hard to be like, well, tell me about how much you're vaping. What do your cartridges look like? How often are you actually using it? We don't ask that well because we're still learning too in the healthcare system. How do we actually quantify this? And I think that's a next step and opportunity for helping folks with tobacco cessation.
Yeah. Interesting. Are there other types of cancers you deal with that are not just caused from tobacco use, but other types of things? And what are those?
Yeah, so we do screening for all sorts of cancer. Obviously, we do breast cancer screening, which we look with mammography. We do cervical cancer screening with PAPS, colon cancer screening, and that's a part of the routine primary care practice. We don't screen for every single type of cancer. Sometimes it's because of a limitation in the study, the safety of the study, or the intervention you might do. But in a daily primary care practice, you talk about all kinds of cancer prevention and if there are recommendations for screening.
Yeah. Have you looked at the Zen usage, or have you seen any data on that? No, no. I
I've heard of them.
Yeah.
You tell me what you've read. I was like, educate us.
Well, the Zen is actually, I don't know about the health effects exactly. I mean, the idea is that anything you put into your lungs is obviously, not great for your health. Maybe the Zen's slightly better because, you're just in the oral area, but then you're worried about, are you going to get orphangeal cancers or all that kind of stuff. The issue that we're having is that more and more young people are using these products, leading to early on nicotine addiction. And it seems like the last number I saw of the number of this product sold was more product and millions was like twice the number of people we have in the United States. So like 800 million or something like that. Cans of this were sold, and they're having problems keeping it on the shelf. And so it's called the Zendemic. You had the vaping epidemic, and now you have the Zendemic, and nicotine is not good for developing young brains. And so how do we approach these? How do you talk to young folks in your office about some of these issues? What does that conversation look like?
Yeah, I mean, we use a lot of motivational interviewing techniques. And so a little bit of it is approaching it with curiosity and just saying, "Well, tell me, like, when are you using it? How'd you get into it? Are your friends using it?" And sometimes folks will be able to tell us about patterns that emerge, like, "Oh, I work 12-hour shifts. It's really busy, and this is what I do to kind of keep myself calm, or what I do when I have my little bit of a break." Or honestly, I'm just using it when I'm out with my friends, and this is kind of the thing that we all do. And so you can unpack that a little bit. You can ask folks, "Well, thanks for letting me know. I really appreciate you bringing that up. It can be hard to talk about. Well, what do you think about quitting? Where are you at? If you had to rate from 0 to 10, with 10 being, I'm ready to quit right now, and 0 being, I'm not at all wanting to quit, what would you rate yourself at?" And someone might say 4, and you go, "Gosh, you could have said 0. Why'd you say 4?"
Yeah.
And then you'll really get into folks being able to say, "I don't know, like, my grandpa had lung cancer. I'm a little bit worried about that." Or, "I've had a couple people tell me that they've quit and it's been really good for them, but I just don't really know how to go about it." And so you can kind of see where folks are at and meet them and partner with them to develop a plan, and or even say, "It sounds like today you're not quite ready. Is it okay if I call you in a month and see how you're feeling about it?" Or, "Why don't we wait until finals is over? It seems like finals is a really stressful time. We'll call you in a couple weeks. Let's get you back in. Let's talk after the holidays are over." And you can kind of just keep touching base. I think people feel like it's a safe place and they're not going to get judged. They'll bring it up. And we can bring it up too as well.
Excellent. When you have the conversations with people in the lung screening program, do you talk about tobacco cessation?
Absolutely. That's a big, big part of it. Yeah, not a big part of it, but that is part of it. I do offer it to them, and if they're interested, some say sure. Then I refer them to our smoking cessation counselors, and a lot of them say no, I'm not ready, and a lot of them have already quit smoking. So then we do the little happy dance. All right, let's go on to the next steps. Yeah,
Excellent.
yeah.
I've seen some numbers that most people have, the desire to quit. They know that it's, maybe not a healthy choice for them. Do you see that people express the desire that they want to?
Desire, but then they're not ready yet, or they go on and they switch from cigarettes to the vaping, although there's that nicotine addiction. So then they left their vapor at home, but their buddy had the cigarette, so they're right back to the cigarettes and stuff. It's tough. Quitting smoking is tough. We become those of us that smoke, which I did at one time in my way past. You become a professional quitter until you finally get there, right? Yeah.
Do you have any maybe some inspirational stories that you can share with us from folks in the program, or things that kind of come to mind that you're able to share with us?
Well, I have a good story of how lung cancer screening does save lives, and it's actually gonna be the first patient I was ever involved in with screening, so it was not at OHSU, but the very first lung cancer that we found from screening I was at the VA previously. It was one of our first patients, and they found a little tiny spot on his lung, and the whole team looked and decided he should go for surgery, so he went on to surgery, and that little spot turned out to be a small cell lung cancer, which tends to be one of the more aggressive cancers that we have a really hard time finding small enough that we can do surgery. So that's great. That's a very successive screening. He went through all the follow up for you have for lung cancer surgery. Finally, came back into screening with me. And about 2 years later, we found another small cancer, not a small cell, but it was called an adenocarcinoma at that time. So not once, but twice we were able to find things early in him and help him. So that right there tells me how lung cancer screening can really save lives. We find it early when we can help. So yeah.
That's absolutely incredible.
Yeah, it was pretty incredible. It was pretty incredible. Yeah.
It seems like you get really close with those patients as well.
Oh yeah. 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 Which is it's a fun part of the job for me. I have patients now who they call to ask if they understood what the doctors told them after they got their scans. If they found some, they call, okay, they said this, and then it's going to be this. Does that sound right?
Yeah.
So it's great. Yeah. Yeah.
Seems like
I
it's
appreciate being that point of contact. I hand out my numbers freely. Always have patients can contact me anytime for any reason. And yeah, so it's great.
I would say that sounds absolutely incredible. And maybe after this, we can talk about how we can bring that program to Douglas County, because that would be amazing.
Yeah. I think everyone should have an Anne, is how I feel. It's like we'd
Yes.
be in a really great place if we could just figure out how to clone Anne and place her all over the country. She hates when I say that.
That would be amazing. I mean, patients, it seems like they always do better when they have an Ann who they can sit there and talk to. And did I hear this right? Um, which is, yeah, absolutely incredible. And I wish I had an Ann too. And I could, yeah. Do you have any stories that you could share with us that?
I don't know if I have any good ones like Anne does. I think the thing that I think about though is in my like clinic or when I'm in the hospital, we sometimes end up diagnosing lung cancers when they become symptomatic, like a cough or weight loss. And the whole point of screening is that folks don't have any of those symptoms. By the time we do lung imaging in someone who has symptoms, it's usually a lot farther progressed. And so, having a conversation when someone feels fine, is not having respiratory symptoms, is the really important part. Because I have lots of stories of when I found cancers with the team in the hospital when they were symptomatic. We knew that there was something going on. And that's when you end up with the more distant staging. So if we can get folks who are not experiencing any symptoms of lung cancer to get screened and find something early, we can have really wonderful outcomes and folks can get back to doing what brings them joy in life and they get treatment and they move forth and that's kind of the end of it, which is really lovely and not something that people associate with lung cancer. And it's a bit of a culture shift to get everyone in the community on board that like if you catch cancer early, it's super treatable, but also get clinicians on board. So getting people to have the conversation early and often and get them connected with someone who can help them get through the system is really important.
Does the program do any like widespread media messaging or things like that about talking about this early screening?
Yes.
We go to various outreach events, and we're working on expanding that, also working on just internal outreach to patients and, getting the word out as best we can.
Yeah. Do you
Yeah.
have any recommendations for us? I know in public health we would love to join, those efforts and work with you folks on how to better improve that message or, can we use funding to help those areas? What could we do to, help you in that really important work that you're pursuing?
Oh gosh, I might not be the right one. It's B over there puts together the event. Sorry.
Well, I think, talking to your local hospital system and say, okay, so are we offering low dose CTs here? Who manages the results? Where can we help? Do you want to partner with primary care? That's kind of what we did at the beginning is we went out to all of the primary care clinics and said, we're starting this program. We want to take this off of your individual plate as a PCP. If you have questions, talk to Anne. If you're thinking the program's going well, or maybe there was something that you want to change, let us know. Let's build this together. And that was received really well. And now everyone knows Anne. It took us a year, but we did a lot of road shows. And so figuring out what you have in your community and then identifying the gaps and saying, well, gosh, maybe we can get do we have someone who can do the nodule sampling? Do we have someone, are folks going to need to travel for their cancer care? Can they get that here? And how do you partner then with other institutions? So we're lucky in Oregon that we've got a lot of great folks, but we also know that there's many communities in Oregon, the vast majority that do not, they're in healthcare deserts. And so how can we get folks in these catchment areas into a place where they feel they have a trustworthy person and how can we get them to care? Because we don't want someone to avoid screening because they're worried that, well, what's going to happen if it's positive? There's nothing for me. That's just not true. But I think partnering with your local agencies to figure out where are the gaps and trying to close those gaps is important and would be really helpful.
Yeah, no.
Well, I think with cigarette smoking, we talk about lung cancer, right? But cigarettes actually cause a whole lot of different cancers, and they're very responsible for you start up here, the head and neck, and sometimes it spreads to the brain, and you go to the esophagus and the bladder. And cigarettes do a lot of damage to the body. So the more we can get people engaged with smoking cessation, the better it is for them, for us, for everybody. I think that's important too. It's not just lung cancer you might get from cigarette smoking,
All types of other cancers.
all types of other cancers.
About HPV cancers. I know that's sort of a big area here, and that's kind of,
Yeah, so we know that I mean one of the coolest things that's happened is that we now have an HPV vaccine and it's one of the first vaccines we have that prevents cancer. And, we know that it can affect all kinds of general cancers. It can do oropharyngeal cancer and cervical cancer. And so, what we want to make sure is that folks are getting immunized. And you can get immunized when you're 9 or 10 years old. It actually works really well. And if we can get kids immunized, they have a lot of protection against cancer. And I just think that is so amazing that we actually have a cancer prevention vaccine. And so, campaigns to get younger kids immunized, but also up to age 45 for many payers. you can still get the HPV series. So if you were just slightly older when it came out and we're told, you're out of the age, that's not the case anymore. So most private payers, you'd have to check with their insurance, will cover the HPV immunization. And so I think partnering with other agencies or clinics where you can, or school-based clinics where you can get kids the HPV vaccine or make sure that folks are talking about it with their adults can help to prevent. Because we know there's a couple of strains of HPV that are the ones that cause cancer, and those are the ones that are in the immunization and can protect folks. So that is the most upstream that we could do is, there's other countries that have said we want to make HPV obsolete. And I think with the immunization, we certainly can.
And then looping this back into tobacco, misinformation and disinformation is sort of a massive topic that I'm sure we could do a whole nother podcast about. But for vaccine hesitancy, all that, I see a lot more misinformation. But I've actually seen some of it for tobacco as well, especially among like vaping. We're getting lots of youth reporting this is just water vapor or, um, uh, just things that aren't particularly true when it comes to most specifically vaping. I'm just curious, have you heard any sort of misinformation or folks in the program who maybe were a little misinformed or just unsure of the facts around cigarette use, vaping, nicotine use in general?
Well, with lung cancer screening, a lot of people don't understand lung cancer screening in general or the cigarette correlation, but I don't actually talk vaping that much in my role. So,
Sure.
yeah, yeah.
What are the conversations you have? Or I guess what are these like is there any when you have pushback, is there a certain thing that folks go to and say, this is where you got me, or
No, it's usually I'm not interested or no, thank you or that's not for me or and that's they have a right to say that. I don't feel like I should say no, but you need to do this. That's not my role. They understand it's their thing. Yeah.
Well, that's really amazing. It sounds like you provide an open space to provide this great health screening and suggestion, and patients have their own autonomy to choose to elect to do it or not, or get more information.
And there's so many great resources out there with more information that is not coming just from me. I can refer them to the websites or send them stuff or whatever it takes, whatever they want.
Yeah, and you really take the fear and the scariness out of this, thing that can be very scary for patients, but then come to you with their questions and concerns, and they seem like they really feel heard and listened to as well.
Yeah, I try. I try, and I'm very, very fortunate to be where I'm at because I can also promote. We have a great team. They're worried if we might find something. I'm like, but if we find something, we have the expert eyes. We have the Dr. Lee, who's a very skilled interventional pulmonologist, and we have Paul Schiffer, the thoracic surgeon. Again, a very skilled surgeon that I've worked with him for years. And we with our chest radiologist, Chara Reidzek. I'm not sure I said her name right, who will all look at things and decide what the best steps are for patients. And I can tell them that. I can tell them that with confidence. And I think they hear my confidence and they can feel a little more confident. It's like, okay, I can do this and I'll be okay if we find something. Yeah.
So this really is a full circle program where you're able to have, the screening technique, but also resources to provide them. Is that pretty important in something like this?
Absolutely. Yeah. 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 Because if we find something, which, we're not, in most scans, we don't find something, but the ones we do, we need to have something that we can do about it. So to have that multidisciplinary approach where you have the best eyes looking at your scans. Yeah.
Is it possible for like rural healthcares to be able to do something like that? I know maybe our concern is, yeah, we can go out and we can promote these screenings, but maybe we don't have the right healthcare. Can we build those programs to be as good as the one that the good as job as this program is here?
It's always been very difficult, right, coming from the VA where we have a lot of rural veterans, and how do we get them back up to the big city for these things that they need? I think a lot can maybe be done with online and digital imaging and stuff, but I think in the end, if you end up needing a surgical procedure or whatnot, you're probably going to need to come to a big city that has the ability to support a thoracic surgeon and have robotic type of interventions that we can do.
Is there a uh, controversial opinion that maybe either one of you hold or have, or is there out there in the world of tobacco as far as lung cancer screening, cancer, things
I'm
like
not a
that?
very controversial person, so I don't know if I have any controversial. I mean, I think if there's a piece of information that I hear sometimes is if folks have been smoking for a really long time, there can be a message like, "Well, what good is it gonna do me to quit now?" And I think it's really important to let folks know that you will notice improvement every day that you don't smoke. So there is any age is okay. Even if you're eligible for lung cancer screening, great, we'll get you the screening. But today is a perfect day to quit smoking, and making sure that folks feel at any age that they can be supported in that and they will get health benefits from it is something that I want folks to always know about. Even if we're talking to someone who's in their 70s or in my clinic in their 80s, it's like, you can quit now and you're going to feel better. You actually are going to notice that things will get better for you. And so keeping that message forward, beyond the lung cancer screening, any age is okay to quit smoking. And there's things that we can do to help.
Yeah, we have a great, chart that's, now on a little card that I give to patients that shows what happens day 1 or just, the first couple hours after quitting smoking, and then at 15 years, you're actually not lung cancer screening is no longer recommended for you because your, lungs have healed themselves as best they can or whatever, yeah.
That's amazing.
Yeah, 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 it is.
It really is
It
cool.
yeah,
Do you have like maybe we have that little card, but like, day one after quitting smoking, it's like your heart rate decreases, or is that something like that?
those kinds of things, yeah, yeah.
Yeah, I think we have little, those cards in our office as well that I like to hand out. I would love to be able to do that for things like vaping. That would be like, hey, here's the thing that you can do. But we just don't have all of the research needed. One of the interesting things that we've explored recently is we talked with another doc at University of California, and he was saying that they did a recent study on mice where they found that I think it's polyethylene glycol or one of the carrier units, maybe it was I don't know, one of the carrier units in the vaping devices, while it didn't cause cancer, it was looking like it metastasized cancer if you had it way quicker than normal. And so his words were, vaping may be a little bit better than cigarettes, but not by much. They're probably, if a cigarette's 100% bad, then vaping in consideration with that would be 80 to 90%. And so it seems like the more research that we find, the more we're learning about all of these products, we're not finding benefits of these things, or they're getting worse and worse and worse.
Yeah, I think it will be really interesting to see what keeps coming out about vaping as there's a lot more like folks are saying exactly what you are, which is we need more information. Like let's get the data and there's tons of people studying this. And so this is going to be something that I think we see like every year we're going to see new information about vaping and then see how it really stacks up against cigarette smoking.
I think my biggest fear too is that tobacco companies continue to have new inventive ways to sell their products and avoid legislation and loopholes and all of that. And so it feels like public health finally did, and all of us really did a great job about like, let's cut down cigarette smoking. We did an amazing job. We worked really, really hard. And now we have less than 3% of teens smoking or using cigarettes, which is fantastic. And, the health benefits, we're going to see that for years. And then it's like, wait a minute, now we have some new products coming in. Okay, all right, now we got to deal with this issue. So, my thing is like, what's next? What's in the next 10 or 20 years? Are there going to be more stuff? Or are we able to maybe come together and actually solve this problem once and for all?
That's a good question. I think there's a way to brand it as like tobacco cessation, which we currently are doing, but the needs of someone who are using like the Zins or chewing tobacco are going to be a little bit different than someone who's smoking cigarettes and someone who's using flavored vapes. And so finding a way to more holistically say, okay, for any type of tobacco use, we found that folks who are doing, chew have a lot more success quitting using this mode versus kind of the same package of products that we have to support. And we're getting better at different like nicotine replacement therapy and medications that can help folks too. So I think trying to consolidate and say, well, let's use all of the same effort that we did toward quitting cigarettes to quitting nicotine or tobacco use.
Is there something that public health could do to help providers directly, as far as like, hey, if my patient came in with this information, it would make that conversation go so much easier. I don't know if there's any specifics or things like that that maybe would be beneficial to providers.
Just if you get a lay of the land and you can hear what you are hearing from folks, if it's unfiltered, that's really important to go, "Oh, that's actually this is must be something that's happening on social media, or this must be something that's getting perpetuated in different communities. Like, let's make sure that we can have a targeted campaign to address that." Or maybe people aren't feeling comfortable asking us about this part of it, but I'm hearing from my public health friends that this is what they're seeing. And so I think just having an open line of communication, working with your local teams and saying, "How can we continue to collaborate?" is kind of the key. So you have a bigger team, you have wider reach, you have people that can chat with you, chat with Ann, chat with me, and we all kind of can come to the same conclusion on how we can support folks.
One thing you mentioned earlier too was you don't specifically read these forms that they come in the office and they fill out, their smoking history, but they all say smoking and they don't necessarily say you have to specifically ask for vaping or nicotine products. I found that a lot of the in offices in my area, they have the same issue and it's not quite clear on how do we update these forms to be more inclusive of other nicotine products. But then also, do we have the data to know what that means? And I think that can be tricky too.
I think that's the tension is that there are so many forms that you have to fill out anytime you come to a clinician's office. What we want is that if we get that information, what are we going to do with it? Are we just collecting it for the sake of collecting it? Are we collecting it because we can intervene or we can offer something? We recently, in our electronic health record, kind of updated our tobacco section so it has more granular information about vaping now. And folks were like, "Oh, finally! Now I can actually like put it in a way that we could probably measure and pull out." But there's a tension is if we have people do 10 forms, it feels like that message is distilled. So we probably need to prioritize asking folks stuff that's really important. And every kind of clinic will decide what that threshold is for themselves.
Yeah, excellent. I always like to end these things with what is your favorite part of your job or the work that you do?
Oh, I like people. I love the patients. I love working with the doctors. I really like trainees too, like med students and nursing students. It's really fun to engage all across the board. So yeah.
Yeah, similarly,
Yeah.
I love working with patients, but I also really like working with teams. And it's been very fun to get to work with this multidisciplinary team. And I think see the day to day benefit of how many folks were getting screened and how many folks that were getting into care quickly is it's just nice to see when the system is working smoothly and it's doing right by patients. And so that's been a really renewing part of this work. And it's been I know my patients have directly benefited from it. So I'm happy that we have this program and I hope that we can support getting all Oregonians screened and helping support them in tobacco cessation.
Absolutely. This conversation has been so exciting and thrilling to me. And there's lots of little bits here and there that I'm like, how can I take that thing that you're doing now? How can I get Ann back to Douglas County? If you want to move, that would be fantastic. We'll set
No,
you.
no, 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 Mitchell.
Yeah, we really appreciate your time and investment in this. And you guys are doing a fantabulous, if that's a word, work. We really appreciate it. And you are setting an example for rural healthcare providers in all of Oregon to look up to you and be like, this is a fantastic program. How can we do this? Or how can we replicate this to improve health outcomes for all of Oregon? So thank you so much for your time and being here. And yeah, you're both fantabulous. We love it.
Thanks, Mitchell. I appreciate all the work that you're doing too. It's just great that you're getting this all out. So good job.